You know, you mentioned risk, and Jessica, as I transition to ask you the question, we see patients all the time, and we know in our heart of hearts when they come in, they're very severe. This is a patient who may need surgery or probably should go on an early biologic. And then there are other patients that maybe in referral centers we don't see as much initially, but are not as severe. But how would you risk stratify? And I know the AGA, the ACG, different organizations have put together these kind of risk profiles for who's going to need surgery, who's going to be that bad outcome that David mentioned. What are some of those risk factors from a practical standpoint? How do you look at these and making a decision on more aggressive therapy early?
Yeah, thanks. And thanks to David for really setting me up quite nicely here. And so, as you mentioned, a lot of our societies have really put together a lot of guidance to help practicing clinicians. But generally speaking, when you're sitting in the office with a patient, and perhaps this is a new diagnosis, somebody you are working up, you really want to be thinking, is this patient set up to have a bad outcome? Because you do want to be attentive to that and be able to address those concerns early with your treatment strategy. And so when we think about overall risk factors for potentially bad outcomes or more severe disease, we're thinking about things that Marla was already discussing, you know, early diagnosis. How young were they when they were first diagnosed? How young are they when they're coming to you? Do they have extensive disease on the workup you've done? Is there, you know, for ulcerative colitis, do they have pancolitis? Do they have significant bowel involvement in Crohn's disease? Have they already required multiple courses of steroids by the time they're coming to see you? On endoscopic assessment, do they have got deep, very deep ulceration? Do they have perianal disease? So signs of systemic inflammation, very high CRP or ESRs on your lab evaluations. Have they already had infectious complications like C. diff or CMV? And certainly in our Crohn's patients, we certainly worry about our stricturing and penetrating patients because we know that they're potentially more likely to have worse outcomes. And the reason why this is important is once you've been able to early identify somebody who is high risk, just as David was alluding to, you really want to be aggressive with those patients. You want to put together a treat to target strategy for them, because as we now know, just treating to clinical symptoms is not enough. You really have to be setting defined objective goals, endoscopic healing, histologic markers, lab values. You really want to be following targets very closely in these patients to ensure that you are achieving the outcomes that you set out, because if not, these patients are much more likely to have increased bowel damage, need for surgery, hospitalization, and disability, as David was just alluding to.
Good. So I think, you know, you touched on some important themes, and ulcerative colitis, that younger onset, severe pancolitis, deep ulcers. I think that's one factor that we all see, whether it be Crohn's or ulcerative colitis. Seeing deep ulcers on the initial colonoscopy really is a factor by which I think prognosticates in a more severe pattern and probably will require surgery unless we do something early. So as we move in a few minutes or to our next topic about treatment, that's probably something that will guide what we do. Perianal disease, you mentioned, infection, CMV, C. diff. So I think these are all factors. But Jessica, let me stay with you for a minute and then we'll open up to the group. In terms of the extraintestinal manifestations, so how do you look at those, and maybe also how do those play a role in terms of prognosticating severity of disease, response to therapy? So tell us a little bit about EIMs and how you approach those and what those are.
Sure. So extraintestinal manifestations are essentially just that. They are extraintestinal manifestations of the disease, whether they directly link with bowel activity or not, depending on which EIM we're talking about. But certainly things like skin manifestations, rashes, uveitis, PSC is considered an extraintestinal manifestation of IBD as well. And certainly these characteristics do put patients in higher risk categories, not only because it's sort of a more extensive sign of disease in these patients, but also they can be much more difficult to treat in times because sometimes our therapies are not directly targeted at treating those EIMs. And so you have to really work with the patient to come up with a therapy that will not only treat their underlying bowel inflammation, which sometimes does in fact treat the EIM, but not always. And so you do have to be mindful that if even with achieving good endoscopic and histologic remission in your patients, the EIMs are still present. You do need to come up with a strategy to address those as well, and it can be quite challenging.